Hello everyone, guten Tag. My name is Nikola Todorovic. I am coming from Applied Bioenergetics Lab, University of Novi Sad, Serbia. So today I'm very happy to present one of our latest research from our lab. So we all know that a good night's sleep is very important for the recovery. But what happens when we don't get enough rest? So today I will take you to our investigation how sleep deprivation impacts creatine metabolism biomarkers in healthy young males. So creatine is probably one of the most researched dietary supplements, and probably one with a solid background as research as a nutrient. However, little we know regarding the sleep deprivation, how actually creatine affects sleep, how actually sleep deprivation affects creatine metabolism. So therefore, we hypothesize that sleep deprivation will lead to a reduction in energy levels and may also contribute to the decline in creatine availability. So this is just some basic stuff regarding the creatine. So creatine is a derivative of amino acid glycine, is naturally produced in our body, primarily in the liver, while in smaller quantities it can be synthesized in kidneys, pancreas, brain, and testicles. Creatine is responsible as an energy donor, and it helps to produce fast energy to the replenishing of ATP. So therefore, creatine is essential for metabolic function. Mostly when we think about creatine, we think about the clinical trials. But we wanted to change this approach a little bit and have more basic or fundamental studies about creatine nature. So we know that creatine is effective in many cases, in many diseases, in many settings with athletes, soldiers, and etc. But what about creatine metabolism under some stress conditions? Previously in our lab, we have several investigations that evaluated the creatine metabolism under some stress and some stress demands. So for example, we had the one very nice study among 12 e-sport athletes. We evaluated their creatine levels before and after 6 hours of gaming session, and actually creatine levels significantly decreased. Additionally to that, we have one other study that affects the short-term fasting effects of biomarkers of creatine metabolism in healthy young men and women. Here, the creatine actually after 24 hours of fasting did not change, but rather its precursor, guanidinoacetic acid, also known as GAA. So therefore, we wonder what would happen with creatine after the sleep deprivation. To prove that, we recruited 16 healthy young males. They were all free from any usage of dietary supplements. They were subjected to 24 hours of sleep deprivation, and they were closely monitoring by research staff inside of our lab during that time, especially during night times. Also, they were instructed to be fasted 12 hours before the baseline and follow-up measurements. We took the blood samples and measured the levels of creatine, guanidinoacetic acid, and creatinine. So what were our results? In contrary to our initial hypothesis, and this is very interesting, creatine levels, rather than decreasing, actually increase from 48.63 micromoles per liter to 63.84. Other biomarkers of creatine metabolism, such as GAA and creatinine, stay more or less stable. If you look closer to our results, we can see that in 11 out of 16 participants, creatine level actually increased. In 2 participants, creatine levels stayed more or less the same, while in 3 participants, creatine levels decreased. So how to explain such results? There is several possible solutions. Firstly, there might be, because prolonged wakefulness is very energy demanding, so therefore maybe there was an enhanced endogenous creatine synthesis to support and sustain energy-intensive neural activity during prolonged wakefulness. Secondly, sleep deprivation might alter the kidney function, therefore reducing the clearance of creatine via renal or extrarenal pathways, therefore increasing the levels of serum creatine. At the third place, sleep deprivation might affect the integrity of blood-brain barrier, therefore diminish cerebral uptake of creatine, potentially due to sleep deprivation alterations. Finally, instead of uptaking creatine, brain might have increased efflux of brain-derived creatine into the circulation due to maybe neuroinflammation. And the fifth solution is, or hypothesis, is that maybe there is a combination of different mechanisms that actually affects creatine metabolism. And at sixth, probably there is maybe as yet undefined mechanism, since sleep deprivation is very complex state that affects our organisms in a very systematic way. So maybe there is something that we still don't know, and the possible areas for investigation could be the shifts in mitochondrial function, or some changes in endocrinal signaling, or some changes in integrity of gut microbiota, which could lead to increase or altered creatine homeostasis. Of course, as any study, also this study has several limitations. At first, we want to note that there is like a relatively small sample size that limits the generalizability of our findings. Additionally, our study focused exclusively on healthy young males, which limit the relevance, the results to the other populations. For example, there is some other populations like the fire workers or tactical military or police forces that working, third shift workers also, that works and have been subjected to sleep deprivation very often. So maybe there will be interesting population for future studies. Also, we did not include any gender diversity or comparisons. Finally, the dietary control, although we watched and monitored our participants very closely during the night hours, during the day they were instructed to maintain their regular diet, which could contribute to the variability in total creatine intake throughout the day. Finally, as I said, as it was mentioned in previous slides, to improve is to change. To be perfect is to change often, so probably we need to change our perspective regarding our research from times to times to make the science better. Thank you for your attention.
Todorovic, you stay perfectly on time, and then we go to the next speaker. I hope I pronounce in the good way. His surname is Ali Gordjinejad. That's okay. Yeah, but for me probably. He will present about creatine, single dose of creatine that improve cognitive performance and induce change in cerebral fluid, high energy phosphates during sleep deprivation.
Yeah, thank you very much. My name is Ali Gordjin. I am from Forschungszentrum Jülich in Germany. And as Nikola perfectly prepared the condition that what is sleep deprivation, what has a negative effect, or suggestions how to solve it, or how to prevent the negative effect of sleep deprivation. So what we did, and that was also our last study, is to study the impact of creatine on sleep deprivation. So first of all, there's nothing to disclose. And yeah, in the second, we came to the idea, since we have read a lot of papers and there was a lot of suggestions that apparently creatine has the potential to overcome negative effect associated with sleep deprivation. Apparently they are both impacting the same, the same kind of metabolites in inverse way. And moreover, since sleep deprivation is leading to impairments in cognitive performance, in turn, creatine creatine has the potential to induce improvements. So, but what was the problem? Why nobody did it up to now? It is associated with a lot of challenges, since Darren described it perfectly here. You have a lack or an absence of creatine transporter in the astrocytes surrounding the blood-brain barrier. So you have a marginal uptake of creatine. And that's the biggest challenge. Therefore, it takes a long time. It's time-consuming. It takes months, weeks, even months to have an effect. But nevertheless, some papers or a lot of studies reported that apparently after intense exercise by athletes in sport, you have an increase in uptake of creatine. And that was also the inspirations in our study. We thought, okay, let's do it the same by the neuronal cells. Let's do a stressing condition for the neuronal cells. By the subjects, they had to undergo sleep deprivation associated with cognitive performance. So, and then let's see what happens. So it was a pretty small study, 15 subjects, but double-blind randomized, crossover, longitudinal one. We started with the baseline measurements in 2 sessions. In one, they got placebo, which was cornstarch, in the other, creatine. And then they repeated the measurements in the subsequent measurements until in the next morning, 4 a.m. And during every session, we did metabolic measurements to get an insight, as well as cognitive performance. So, and then we compared both to each other, and the results was amazing, more than expected. In almost all metabolites, we got changes, particularly regarding the total creatine, which has been increased, interestingly also in the left parietal one, and also a decline of ATP regarding the creatine session, since this is a sign that apparently if creatine is available, ATP is going to be used to generate phosphocreatine, which is needed by high energy consumption. All that happened, and most interesting, very interesting, we got also a drop in the pH level, also a typical indication for creatine supplementation to prevent an over-acidification. So that was the half story. The other also, we got improvements in almost all cognitive performance, particularly regarding the short-term memory task, focusing on language, as well as in the speed in processing time, also very impressive. All subjects were much faster. So all that, and comparing both to each other, you see here what survived. Highly significant was the short-term memory, part regarding language tests, as well as speed in processing time. Interestingly, also the radiological left hemisphere was also highly affected. So apparently, so it works in a short time range. That was a big deal. That was the first result. Interesting is, so here are the explanations why we think what happens. So one explanation is, okay, it is in hyperammonia. Within sleep deprivation, you have an increase of an ammonia level. And ammonia level increase in hyperammonia is increasing the expression of creatine transporter within the astrocytes, the missing point by a high uptake. The second one, here we have also this so-called sodium-hydrogen exchange, and that happened if you have a drop in the pH level or over-acidification. This mechanism or this activation is going to transport the excess of hydrogens into the extracellular space. In turn, you have an influx of sodium. And sodium is also a co-transporter of creatine. And that is maybe the reason why you have an increased influx of creatine. So with other words, to prevent the over-acidification or stop the drop of the pH level, you have this effect. The other is the second one. It is also activating insulin, so, or releasing more insulin, also a co-transporter of creatine. And nevertheless, last but not least, also increased ATPase-related sodium-potassium gradient exchange, since you have higher neuronal activity. And this is, and since sodium is also co-transported with creatine, this is also the second or the last part. So coming together or bringing the conclusion is that, so indeed it has the potential within the short time range. That was a big deal, got also a lot of international attention. But the point is, it was a huge dose. It was roughly about 20 to 30 grams, which is a lot. And you can imagine for the kidneys as a burden. We are now going into the next step in the next study to check or to figure out whether a lower dose is also working. And if so, you can imagine how interesting this is for firefighters, nurses, pilots, students before exams, and so on and so forth. Thank you very much. You see here, I was not prepared with that. We got a lot of international attention, more than expected. Thank you very much.
you. And we go to the next speaker, that is Dragana Zanini. She will talk about dietary creatine and the risk of mental health condition in the general population.
Thank you. Okay, so the incidence of mental health difficulties and disorders are rising worldwide. So there is necessity for some beneficial, cost-effective, and safe adjunct therapeutics that will help in treatment of mental health disorders. The preliminary studies shows that creatine might have beneficial effects and antidepressant-like effects. Nevertheless, the research with non-US based populations and other than depression outcomes, other mental health outcomes than depression are still lacking. Therefore, the aim of this cross-sectional epidemiological study was to investigate association between dietary creatine intake and the risk of mental health outcome at the general population level. So we use data from the Korean National Health and Nutrition Examination Survey around from 2022. The sample is comprised of 5,257 participants, of which 56% were females, with a mean age of 51.1 plus minus 19 years. Eligible participants were older than 12 years old, and those who had dietary creatine intake records and at least one measurements on mental health outcomes. So the daily creatine intake was collected through 24 hours food recall interviews. And then we calculated daily creatine intake thank you, as average creatine content from meat-based and dairy-based products, excluded creatine from food supplements and pharmacological sources. Dietary creatine intakes was quantified as relative amount. And then we, after calculation of dietary daily creatine intake, we classified all respondents in quartiles that we used as independent variables in the subsequent analysis. Concerning mental health measurements, we used data about depression, suicide risk, generalized anxiety disorder, perceived daily stress level, and mental health status. So about depression, we have more than one outcome. We have a questionnaire, patient health questionnaire with 9 items, with score of 10, indicating above 10, indicating the presence of depressive symptoms. Then we had prevalence, calculating in entire sample and within each quartiles of dietary creatine intake, and we have depressive feelings more than 2 weeks as a binary yes or no. About suicide risk, we evaluated suicide risk as yes or no question to do they have suicidal thoughts, plan to commit suicide, and suicide attempt during past year. About GAD, it was assessed through a questionnaire that has seven items. Also, as in depression, the score above 10 indicating the diagnosis of generalized anxiety disorders, and we also have a prevalence for these disorders. And perceived daily stress level was measured by 4-item scale from Korean disease control and prevention strategy. So this was, we have 3 sets of results. The first are descriptive statistics, and the average daily creatine on this sample was 10.3 plus minus 9.5 milligram per kilogram of body mass. And after that, we calculated the quartiles of creatine intake. As you can see, the lowest one was equal or above 3.71. The second was 3.72 through 7.78. The third was 9.98 to 13.80, and the highest quartile of dietary creatine intake was above 13.80. As you can see from table 1, daily creatine intake significantly was different across gender and age categories, so that men have higher dietary creatine intake than women, and preteens and teenagers higher than adults, and preteens, teenagers, and adults higher than elderly, and this is results that are expected. Then we have another set of results where we want to compare mental health outcomes across the quartiles, and as you can see from figure 1, the respondents in the lowest quartile, Q1, has the highest score on the PHQ-9, the questionnaire that measured depression. Also, you can see that if respondents move from quartile 1 to quartile 4, it is followed by reduction in score of questionnaire by 0.13 points. As concerning prevalence of depression, the highest prevalence of depression is noted in the lowest quartile, and it's 6.9%, and it's significantly different than the others quartiles. On figure 2, you can see the significantly difference between between quartiles considering suicide risk. So in the lowest quartile, there are in the lowest quartile, the respondents had the strongest, significantly highest suicide thoughts and plan to commit suicide and suicide attempts. So all 3 variables was higher in the lowest quartile of creatine intake. Then we have a regression, results of linear and multinomial regression analysis. We want to examine association between quartiles of dietary creatine with mental health variables. And we also applied 4 different regression models. And for the model 1, we held constant biomarkers of creatine turnover, namely creatine in urine and serum. And as you can see in model 1, there is a significant negative association between quartiles of dietary creatine and PHQ-9, and also with depression prevalence, and with positive association with mild level of daily stress. In model 2, that is covariates in model 2 was demographics variables, age, gender, and educational level, and household income. In that model, negative association was found for PHQ-9 and GAD-7, and also for the prevalence of depression and generalized anxiety disorder, but also with perceived level of daily stress, indicating that higher stress, that higher dietary intake is associated with reduction from severe to no stress. Also higher creatine intake, you don't see that from the table, higher creatine intake was associated with reduced risk of depression and reduced risk of generalized anxiety disorder. For Model 3 and Model 4, Model 4 is with covariates of physical activity and nutrition, and Model 4 for covariates of social life and health. There were no significant association between dietary creatine intake and mental health outcomes. So the summary of results. The mean daily dietary intake was 10.3 plus minus 9.5 on this particular sample, and it varied significantly across genders and among different age categories. Higher depression scores, higher prevalence of depression, and decreased prevalence of suicide risk was observed among individuals in the lowest quartile, consuming equal or less than 3.71 milligrams per kilogram of body mass. Mean daily creatine intake was significantly different between respondents with and without GAD, with no differences found for GAD-7. And higher creatine intake was associated with reduced risk of depression with odds of ratio of 0.83, and GAD, generalized anxiety disorder, with odds of ratio of 0.88 in Model 1, and remained robust in Model 2 with addition of significant inverse association with perceived daily stress. No significant association between creatine intake and mental health outcomes in Model 3 and Model 4 were observed. So, conclusion. Dietary creatine as a brain enhancer, as brain bioenergetic enhancer might have protective effects on mental health condition in general population. It might deliver more creatine to brain and might impact some psychiatric conditions that are related to brain metabolism abnormalities. Also, this study expands previous research, including measures of anxiety, suicidal tendencies, daily stress level, mental health counseling as both categorical and continuous variables in a non-based US population. This study also has some limitation, and it referred to cross-sectional design that prevents us to conclude about cause and effect relationship. Not well distinguished various animal protein subgroups in determined content of creatine, methodological shortcomings of screening tools for mental health outcomes, and underrepresentation of non-adult participants. There were just 5% of those who was between 12 and 18 years old. These results in this study are aligned with previous one, implying beneficial effects of creatine consumption on mental health condition, although the results should be interpreted with caution, and that's why the additional randomized controlled trials, and especially longitudinal, are recommendable. Thank you for attention.
Okay, thank you for your interesting presentation, and just a recommendation for all the speakers, just try to stay closer to the podium because of the camera. So for the online presenter, if you go too much out, they cannot see you. So we go to the other next presentation from with Paul Anthony Baker from University of North Carolina. He will present creatine monohydrate increases skeletal muscle microvascular blood flow and promotes lipid metabolism in postmenopausal women. And this presentation will be online.
Thanks to everybody for tuning in, and thank you for the Creatine Conference for having me. Today I'm going to be presenting on creatine monohydrate increases skeletal muscle microvascular blood flow and promotes lipid mobilization in postmenopausal females. So quick disclosure, the creatine monohydrate and placebo powders were provided by Allskim for this study. So females throughout the lifespan, females go from pre, peri, into postmenopause. And what we see alongside that is a decrease in estrogen accompanied by muscle size and quality losses in bone with an increase in adipose tissue. Now, this puts this postmenopausal group to being particularly susceptible for an increased risk of cardiovascular disease. Now, if we look at the earliest manifestation of cardiovascular disease, it is going to be disruptions into blood flow. Now, if we go back to our undergrad physics class, we can see that flow through a tube is dictated by this equation here, with the biggest factor being the radius. Now, if we replace this tube with our blood vessels, we can see that changes to the endothelium, whether that be vasoconstriction or vasodilation, are going to have drastic changes onto blood flow. And with those blood flow disruptions, we can actually see disturbances in metabolites, such as glucose, lactate, and glycerol. And even we can see elevations of reactive oxygen species, otherwise known as oxidative stress, that can further impair that blood flow. So just a quick recap, postmenopausal females have decreased microvascular blood flow, increased oxidative stress, and disturbances in these metabolites. So what do? Well, we can recommend exercise, but long-term adherence is mixed. Nutrition interventions are sometimes hard to stick to. If only there was a simpler solution, and this is where creatine comes in. So as we all probably know, creatine has become evolving in terms of its health benefits. And so Dr. Holly Clark here had an excellent review paper on all the ways that creatine could be applied to vascular health and potential mechanisms. So based on the techniques our lab has, we decided to explore these two in particular, microvascular blood flow and reactive oxygen species. So the technique our lab has is called microdialysis, involves inputting a semi-permeable membrane into the skeletal muscle where we can perfuse in different pharmacological agents and collect things in this collection vial out on the other end. Now, certain things that we can collect are the ethanol. And so we perfuse a certain amount of ethanol in. If that ethanol comes 100% out and being no blood flow at all, what we see is a difference because the ethanol is carried out, and we can measure blood flow by those means. We can also measure hydrogen peroxide concentrations with the different agents we have going in to measure the fluorescent activity. And we can measure our glucose, glycerol, and lactate concentrations. So that led us to a pilot study in 7 individuals, young, healthy individuals, and we had them come in. We placed a microdialysis probe in the vasa sideralis. So here is the ethanol to measure the blood flow, as well as these different ones to measure hydrogen peroxide concentrations. We insert the probe here, and then we gave a high fat and a high carb meal after a 1-hour rest, just to stimulate our ROS concentrations, get them really nice and high. And then we examined that for 4 hours postprandial. Now, after that, they went home. We gave them 5 days of 20 grams of creatine monohydrate. And then we had them come back for the exact same visit, just being post-creatine supplementation. So this is this ethanol outflow inflow ratio. So a lower ratio means that more ethanol was carried out to the liver and means less away from the probe, meaning a higher blood flow where we have that probe at. So here we see no differences at rest. We give them the meal. And for this first 40 minutes here, we can see an increased blood flow after taking 5 days of creatine supplementation. Now, another interesting piece of data we looked at the fat mass from a DEXA scan, and our individuals here that had lower fat mass tended to increase hydrogen peroxide concentrations with creatine monohydrate supplementation, whereas our individual here that had a greater fat mass had really big reductions in ROS concentrations with his 5 days of creatine monohydrate. So that led us to look at what is the effect of 5 days of 20 grams per day of creatine monohydrate in postmenopausal females with overweight and obesity. So for our study design, we took 6 postmenopausal females, had a baseline visit to get body composition and metabolic rate. We had them come in for a pre and post visit in which we administered microdialysis probes into the muscle and gave them a meal, and then randomized them to either placebo or creatine monohydrate. This time it was double-blinded, and so we either did creatine monohydrate or multi-injection powder. They then had a 4-week washout, and then they came back for the same testing conditions, just receiving the other treatment that they didn't receive the first time. Now, if we zoom in on a study arm to see what it looks like in detail, you can see that we insert the microdialysis probes into the gastrocnemius here, our ethanol for the blood flow, and our other agents here for the ROS concentrations. And then our meal was 35% of energy needs with a higher macronutrient count coming from carbohydrates. So same kind of design here, we do a resting hour and then 4 hours postprandial. They do their supplementation and then come back for that same post visit. And then all the data for this is presented as basal plus postprandial. We really wanted to look at what are the long-term implications of doing creatine supplementation throughout the day, so getting a longer time span in there. So the first piece of data is the skeletal muscle microvascular blood flow. So again, our ethanol outflow inflow ratio, and we can see from pre to post creatine a decrease in our ratio, which is inverse. It means an increase in our blood flow. So more ethanol is being carried away from that microdialysis probe, meaning there is more blood flow in the skeletal muscle post creatine supplementation with a no change in our placebo group there. Next is going to be our hydrogen peroxide concentration. So our ROS concentrations here. We see no change with our creatine supplementation. If anything, it made them more homogeneous, with an actual decrease in our placebo concentrations. Now, these red bars are not different. They do seem higher. They came in with higher ROS on that pre-placebo. But the good thing to note here is that there is no difference from post-creatine to post-placebo. So at least no difference on the post-supplementation visits. Next is our glycerol concentrations in the muscle. And what we see from pre to post creatine supplementation, an increase in skeletal muscle glycerol rates with no change in our placebo group. Next is our glucose. Now we see a decrease amongst both groups, but did not reach statistical significance. And next we see with our pre to post 5 days of creatine supplementation, a decrease in lactate, even though this did not reach statistical significance, 0.06, with our creatine, and no change in our placebo. So no change overall with the creatine or placebo. So just to quickly recap what we saw with our studies, improved blood flow and elevated glycerol. Now this is only kind of the beginning of what we'd like to do in future work with microdialysis, obviously larger studies with a greater sample size. This is just looking at 5 days of 20 grams of creatine supplementation. So pairing this with something that's synergistic like exercise or nutrition would likely yield greater benefits. And then also with microdialysis, we can look at mechanisms. You know, it's an in vivo measure, perfuse in different things, look at what creatine having effect. So some of these vascular measures, kind of touching more upon those in the future. And so plenty of room in the area for growth and looking at how creatine could affect various things. So in conclusion, when we gave postmenopausal females 20 grams of creatine monohydrate for 5 days, we see no change in oxidative stress, lactate or glucose, but an increase in skeletal muscle microvascular blood flow and skeletal muscle dialysate glycerol concentrations. So I'd like to give a quick thank you to my mentors and my collaborators and my undergrads. Everybody on the screen helped tremendously with this project, couldn't have been done without them. So big thank you to all of them. And then with that, I'd be happy to take any questions. My email is on there, so feel free to email me with collaborations, questions, happy to take anything that you might have in mind. So thank you again, and hope you guys enjoy the rest of the conference.
Okay, we thank Paul for his interesting presentation, and we have from the same university, Jean Moore. She talked about the effect of creatine loading on cellular integrity and jump performance across the menstrual cycle.
Hello, my name is Sam Moore. I'm a PhD candidate at UNC Chapel Hill. I work in the Applied Physiology Lab under Dr. Abby Smith-Ryan, and I'm excited to present our research today on creatine loading, on cellular integrity and jump performance across the menstrual cycle. Okay, good. Here we go, locked in. Flip it around. I'm not sure what you mean. I'm clicking the buttons, but nothing's happening. Turn around the pointer. Menstrual cycles, am I right? Who's excited about it? Okay. I can just give you a point, and maybe you can do the slide. Do you want to do that? Okay. Thank you. Didn't want him to miss it, you know? Hey, okay, there we go. My only disclosure, and my first disclosure, usually this slide is blank, so very exciting, is that the creatine monohydrate used in this study was donated free of charge from OzChem. Great to see you in the room, and thank you in person. Yeah, here we, oh, now we're using it. Nope, back to the point. Okay, so when I was putting my slides together for this presentation, I was thinking to myself about who was likely going to be here, and how there's really not much that I can say about the background of creatine that you don't already know, mostly because the people in this room wrote the papers that taught me what I know about the background of creatine. And so instead I thought about listing some of the myths that we hear when we present these data. So the first one, and my personal favorite, is that creatine is an anabolic steroid, that it's the cause of muscle dehydration and cramping, but also water weight, and that it's only useful for bodybuilders and people that are trying to get lean mass gain and resistance training twice a day. Instead, what we know is that creatine is safe, it's effective at improving mood, cognition, exercise performance, and recovery, and that it also provides unique benefits to women. Now the back, the clicking is not working. Oh, there we go, yep. So speaking of women, they are the largest market of dietary supplement users in the United States, with 77% of women reporting using some sort of dietary supplement, but despite that, only 17% of women report in the past or currently using creatine as a supplement. And largely that's due to the misconceptions, again, thinking about people thinking it's a steroid, the lack of knowledge regarding all the benefits of creatine, and again, this fear of weight gain. The menstrual cycle, everyone's favorite slide. So, the menstrual cycle is a physiological process that includes fluctuations of hormones that can influence elements of performance, fatigue, and recovery. And we usually split it up into 2 phases. And so the first phase starts with the first day of your period, and it goes until the day before you ovulate, and that's called the follicular phase. Once you ovulate, you've now entered the luteal phase, and that goes until the day before your next period. We can think about the luteal phase like a set of dominoes. So menstrual cycles can vary between 21 and 35 days in length and still be considered normal. And so these changes in length are largely in the follicular phase, but the luteal phase is, once it starts, it's almost always about 14 to 15 days long. There are some key moments in the menstrual cycle. The first one is menstruation, or your period. And this includes a loss of erythrocytes when we shed the uterine lining, and women usually report feelings of bloating and uterine cramps during this phase. During the luteal phase, in the middle, when estrogen and progesterone reach their peak concentrations, we also see an extracellular fluid accumulation. And then as these hormones fall, which signals the shedding of the lining and the starting of the new menstrual cycle, we see increased inflammation and higher reported symptoms related to premenstrual issues. So increasing total body water and intracellular fluid is really valuable for thermoregulatory, exercise performance, and recovery outcomes. And creatine is an osmotically active substance. So effectively it pulls water into the cell, which improves hydration, but can also be associated with an increase in body mass. But this is an outcome typically observed in men. And so in our lab, we wanted to know if the same was true with women. And what we found was that when compared to a placebo, creatine significantly increased fluid volumes in all compartments, with the greatest increase being seen in intracellular fluid and no significant changes in body mass. These results were observed specifically in the luteal phase, so again, when estrogen and progesterone is high. And so we think that maybe creatine offset the effects of these hormones with the extracellular fluid accumulation, and that's why we saw a significant increase in total body water, but no matching increase in body mass. Multi-frequency bioimpedance devices provide a method for portable, non-invasive testing of raw bioimpedance markers that can measure tissue hydration and cellular health. And phase angle specifically is calculated from resistance, reactance, and impedance, and is considered to be a composite indicator of cellular health. And so these measures are typically used in clinical settings for not only characterizing disease state, but also assessing inflammation status. And so the purpose of this study was to evaluate the effect of a creatine supplementation protocol on whole body phase angle and counter movement jump across the menstrual cycle. We had 20 generally healthy, recreationally active eumenorrheic participants that completed the study. And eumenorrheic means that they were not using hormonal contraceptives at the time and that they were ovulating, that we measured with basal body temperature daily tracking. So our experimental design was a double-blind, placebo-controlled crossover study. Participants came in, they performed a baseline visit during menstruation, and then they were randomized to menstrual cycle start phase, so starting in either the follicular or the luteal phase, and then the supplement type. The loading protocol was 4 by 5 grams for 5 days of either creatine or our placebo, which was Crystal Light. And the participants completed this protocol in each of the menstrual phases, again in a randomized order, but with the same supplement type. So the crossover was the menstrual phase. Our measures included acute hydration, so when participants arrived, we used a urine sample to calculate urine-specific gravity and make sure that they were in an appropriate euhydrated range for the device. We then did a multi-frequency BIA test with an in-body 770, thank you, for whole body phase angle as well as total lean mass. And then we did 3 repetitions of a counter movement jump performance. We used repeat measures and COVA tests to evaluate pre and post supplementation differences between treatments and then between menstrual phases. And we used urine-specific gravity to covary for phase angle and total lean mass to covary for jump height. So to contextualize some of our results, we have the individual effects at the top, and we've separated these by phase. But again, to compare across differences in menstrual cycle length, the follicular phase are represented by days since last period, and the luteal phase is represented of days until next period. So we can look at the differences in these phases, even though some women have drastically different lengths in menstrual cycles. And so our key findings here was that compared to the placebo, the creatine group demonstrated significantly greater phase angle at the luteal phase post time point, and that the creatine group also demonstrated a significant increase in phase angle from the pre to post supplementation time point in the follicular phase, while the placebo group saw no differences. For the counter movement jump height, the placebo group demonstrated a significant decrease in jump height of about 3 centimeters between the 2 post-supplementation time points, so from their follicular phase post to their luteal phase post, and that no significant changes were observed for the creatine group at any time point across phase. So our conclusion is that creatine supplementation helped improve cellular integrity measures as measured through phase angle, and that these improvements possibly helped to maintain physical performance across the menstrual cycle, particularly in that mid to late luteal phase stage when we are approaching menstruation and inflammation is higher. Future research could look at these results and their impact on direct markers of inflammation, potentially sleep outcomes, and then other exercise and sport performance markers. These are my references, and that's all. Thank you so much.
Thank you for your presentation. And in effect, there is an aspect that I see in my nutritional practice that women are scared to use creatine because of water retention. So I think it's a very nice word. So now I call Stacey Ellery with the presentation about open label dose escalation trial of creatine monohydrate in pregnancy. It's a very interesting topic.
Thank you very much. Hello, everyone. Apologies in advance for my slide clicker. Oh, I'm good to go. That's very good news because I'm notorious for over animating my slides, and that was going to get interesting. All right, here we go. Get ready to click, 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 click. So first, my disclosures. I do sit on the Scientific Advisory Board for ELSCHEM, and they did provide us with some Crea Vitalis product for the stage 2 of this pharmacokinetics trial. So why take creatine during pregnancy? I have an extended presentation on creatine in pregnancy and the potential use of creatine to prevent perinatal brain injury tomorrow, but hopefully no spoilers to suggest that we are evaluating creatine as a potential dietary supplement for use in pregnancy. But also, as we've been hearing just from Sam then, and you'll hear across the next couple of days, that the potential use of creatine for female specific conditions is fast growing. We have a lot of women that are already taking creatine, and they're very interested in whether they should keep taking creatine during pregnancy. Is it safe? Is it still going to be efficacious for whatever reason they were taking it in the first place? And so really we're primed at this moment to do a pharmacokinetic study of creatine in pregnancy. Now you might be thinking, would we expect the pharmacokinetics of creatine to change with pregnancy? The short answer is, based on other nutrients and drugs, yes. Pregnancy is an absolutely crazy time in terms of maternal physiology. There are so many changes that are happening in a really quick time frame. The most significant of which, from a pharmacokinetics perspective, is that you have this massive volume expansion of your blood. You have around 60% more blood at the time of giving birth at term gestation than you did at the start of your pregnancy. We have changes in gut motility. We have change in renal function. There's a whole bunch of different things happening during your pregnancy that would likely change the pharmacokinetics of creatine. And so to get our answer, we performed this single site, feel free to just keep clicking, open label multi-stage dose escalation pharmacokinetic trial of creatine with parallel arms with our clinical colleagues at Monash Medical Centre. So specifically Dr. Deb de Guingand, who is a midwife who was doing her PhD with us at the time, Professor Kirsten Palmer, who heads our maternal fetal medicine centre at Monash Health, and also Dr. Madison Naidu, who helped out with this study as a part of her obstetric training. So I'll quickly whip through these. We basically had the primary objectives of understanding the accumulation and elimination of creatine supplementation in both pregnant women and non-pregnant women. So we did a direct comparison of pregnancy and non-pregnancy to see if we were seeing those pharmacokinetic changes, and actually did the proper pharmacokinetic calculations and some Monte Carlo dose simulations to really get at what regimen we should be recommending for pregnant women. And then we had some secondary objectives as well, which were mainly around understanding the kind of safety and tolerability of creatine in this particular population, remembering that we've got a baby on board as well. So we've got two patients when we're talking about pregnant women, both the woman and the developing baby. And so we did this study in 2 stages. The first was a single 5-gram dose of creatine monohydrate to both non-pregnant and pregnant women. We then took, after having the dose of creatine, we took hourly blood samples out to 10 hours post-ingestion to get that classic accumulation and elimination profile of creatine. And then the second stage was a multi-dose in phase of creatine monohydrate. We just focused on our pregnant women for this, and it was to gain some data on peaks and troughs that we could then build into the pharmacokinetic model as well. And so getting on to the results, stage 1, population characteristics, nothing particularly interesting on this slide. They were healthy women and carried their pregnancies through to term. This one was interesting. So I just rabbited on about how much we expected the accumulation and elimination profile of creatine to look different between our pregnant and non-pregnant participants. Hopefully you can see here, and as struck as I was, that there was absolutely no variation whatsoever between our two populations. We don't know exactly why this might be. Likely changes in gut motility and potentially the expression of the creatine transporter in the gut. With pregnancy, there have been some rat studies that have shown that's happening. We may be getting more creatine actually being taken up through the gut that might be offsetting some of those changes in blood volume. So we then went on to do the pharmacokinetics calculations and the Monte Carlo dose simulations. I will take any questions about this, the specifics of this on notice, because I didn't actually do them. We went to the experts. So Professor Carl Kirkpatrick in our Department of Pharmacology at Monash University undertook this analysis for us. And really, not sure. Oh yes, there we go. So from our animal studies that I'll present tomorrow, we actually don't know exactly what kind of steady state dose accumulation we are looking for to be efficacious. We've had to use varying doses. They're very species specific, so we're a little bit in the dark there. So what we based our modelling on here was the initial pesky studies where they saw a steady state over time of 50 milligrams per litre in males. We thought that would be a good place to start to show that we could achieve the same level of dosing that's commonly recommended for people for other applications. And so these are just graphs of the Monte Carlo dose simulations and estimations. The things to focus on, am I clicking or are you clicking? I'm not so sure which one's happening, sorry. So the things to focus on here is this green line. That's our 50 milligrams per litre target that we were going for. We did also run the modelling at 100 milligrams per litre target steady state, just as a comparison point. Here is just a table of the results. The thing to focus on here is to get that 50 milligrams per litre steady state within 3 days. We could have achieved that based on the modelling with 10 grams every 12 hours, 5 grams every 8 hours, or 5 grams every 6 hours. We decided to proceed with 5 grams 3 times a day. For the second stage of our study, we just felt that that might be a little bit more appealing to women, potentially a little bit more tolerable to be taking lower doses at multiple stages. But interesting to note that you would likely probably get the same level of accumulation with 10 grams twice a day if that was the way, if that was more appealing to you personally. Okay, so this is the population characteristics of our second stage, remembering that we just focused on pregnant women for that multi-dose stage, or the multi-day, multi-dose stage of the pharmacokinetics trial. Again, nothing particularly interesting. They were a healthy population, other than I thought it was worth noting that we asked the participants whether they'd heard of creatine before. 4 of our 8 participants said yes, 4 said no. I think that that's interesting and something that we need to keep in mind when we look at some of the survey data around tolerability. I think it's important to note that, you know, we had some women there that were likely had keen interest in creatine, and then we had some naive people as well. They would likely answer the question slightly differently, so important to keep that in mind. Now, we only finished stage 2 of the trial towards the end of last year, so it hasn't been, our data hasn't been put into the model as yet. So I've just plotted the raw data here. So we've got baseline, 1 hour post the first dose on the first day, and then we asked the women to come back 3 days later after they took creatine morning, lunchtime, and evening for 3 days. We took a baseline again on that morning of the third day, and then 1 hour post the third dose. And you can see that we are starting to get up around that 50 milligrams per litre target range. It'll be interesting to see whether the dosing modelling differs at all once we plug this data into the model and into the simulations as well. And then just to touch on briefly fetal well-being, this was really important, obviously. We looked at this through doing cardiotocography or CTG scanning. This is the gold standard for looking at how well a fetus is doing in the 3rd trimester of pregnancy. Absolutely nothing interesting happened within an hour post the creatine supplementation in either the first stage or the second stage of the study. And then we obviously looked at birth outcomes as well. Not surprising, they had such small amounts of creatine, it was a small study, but we saw no negative outcomes within our population. So just a couple of quick slides on the tolerability of creatine within this pregnant population, because these questions haven't really been asked before. We had all of our participants across both of the stages consume all of the creatine that we asked them to, which was good. And we had none experience any side effects over the 3 days. We had one participant suggest that it was a little bit challenging to do creatine 3 times a day, something for us to take into consideration as we potentially progress forward to a clinical trial. And we had multiple participants identify some potential barriers for the creatine supplements. So again, for us to build into potential clinical trials going forward. So the take-home message at this stage, the trial is still ongoing in terms of our data analysis and pulling it all together. Is that pregnancy in the 3rd trimester did not statistically change or significantly change the pharmacokinetics of our creatine monohydrate, despite what we thought it would do compared to our non-pregnant women. And we would likely be able to recommend a dosing regimen consistent to what is currently recommended for ergogenic trials, so probably around sort of 5 milligrams 3 times a day, to reach the effective levels of plasma concentrations of creatine that we were aiming for. There were no safety concerns for mum or bub in this small phase 1 trial. And taking creatine up to 3 times a day, at least for 3 days, for a population of 8 women, was very well tolerated, but obviously a lot of work still to do in this space. And with that, I'll just thank, obviously, the women who participated in the study and their families. It's a lot to ask a pregnant person to participate in a clinical trial. They're usually very willing to do so, but we have to remember that, again, there's that baby on board that's not making those choices. And obviously, our clinical colleagues who we couldn't do these kinds of studies without. So thank you very much.